Yeah, thank you very much for the invitation. Really good to be here to talk to you about trial design, and this is an area of interest of mine and my research group. So I'm going to try and give you a bit of an overview of several different trial designs, some traditional, some novel, and maybe an idea which ones might be suitable in different situations, hopefully. So I really think we've seen this kind of thing in the last talk. We're interested in looking at treatments where we have different effects in different types of patient. So in this table here, we might have an example where a biomarker is predictive, which means that high level of biomarker means the patient benefits a lot from treatment B, and low level means they don't get any benefit from treatment B. So in this case, this biomarker is what we call predictive the effect of treatment B. So when this happens and treatments work differently in different subgroups of patients, how do we change clinical trial designs from the traditional kind of randomized controlled trial? Well, ideally, we need to consider what we want from a trial. So ideally, sometimes we want to know whether the treatment works on average. Even if that is the case, or if that's not the case, we want to know which patients do particularly well or poorly from treatment. We also want to treat the patients that have been recruited for trial as best as we can. So maybe if we can accrue information as we go along and make changes, maybe drop ineffective treatments, that will really help to do this. And we also want to be as efficient as possible because the clinical research process is very expensive and takes a long time. So anything we can do to reduce the cost or reduce the time taken, it will be very welcome. So first I'm going to talk about trials which just have a single experimental treatment, usually with a controlled treatment. And this is an area where we've got quite traditional trial designs to use here. So the first one is when we really want to show that the biomarker is predictive. So this is called a marker by treatment design. And it's very similar to a traditional randomized controlled trial. You have a biomarker, and I'm going to simplify it by assuming it's got two levels here. And regardless of what level the biomarker the patient has, they're randomized to experimental or control. And probably the trial would be powered here to detect an interaction. So we'd be looking at not only is experimental better than control, but does the relative benefit of experimental versus control differ in the biomarker positives and biomarker negative patients? And that generally requires quite a large sample size to be powered for a realistic interaction effect. Another trial design that's been used quite a lot is an enrichment design. And I think to some extent all trials are enrichment designs because we always have eligibility criteria for patients. But this is really where we've got some biomarker or something like that where we'd expect only a subgroup of patients to benefit from it. So we might have really good data from previous trials or really good biological reasons to think that biomarker positive patients will benefit, biomarker negative patients might not benefit or might even be harmed by the treatment. And in that case, we'd only want to take biomarker positive patients on and randomize them between experimental and control. Now that's efficient because we need fewer patients in the biomarker positive group and we've got a larger treatment effect. But it's also a bit dangerous because what if we're wrong about the biomarker negative group? Maybe they will benefit from treatment, and as we heard in the last talk, we might lose billions of pounds. What can we do in that case? Well, we can do something called an adaptive enrichment design, which is an adaptive design. I'm not sure if you're familiar with adaptive designs. Basically, they use data that you gather during the trial to make changes and can be very suitable in some cases. So it would look a bit like this, where we have a first stage where all patients are recruited, biomarker positives and biomarker negatives. Then we do an interim analysis after a suitable amount of time, where we look at the effect in biomarker positives and biomarker negatives. If there's an effect only in the positive group, we can continue the trial with an enrichment approach, just recruiting in this case, red patients. If there's an effect in both, we can continue with all patients. And if there's no effect in either, then we can stop the trial for futility, because we're unlikely to find an effect. So now I'm going to move on to trials with multiple treatments and multiple biomarkers, and these are generally called platform trials. Just a quick word on multi-arm trials with several experimental treatments. These are generally a good thing to do because you often have a shared control group. That means more statistical efficiency because we only have one control group compared to doing several trials testing each treatment separately with a control group in each one. Often it's administratively and logistically easier to do compared to separate trials because we only need to apply for one trial, we only need one ethics application, things like that. So there's a lot of savings there. For targeted treatments, where the different treatments might target different subgroups of patients, then this is good as well because more patients in the trial will have a treatment that's targeted at them. But on the downside, they are more complicated to do, obviously, compared to a single trial comparing one treatment, but probably less complicated than doing a lot of trials comparing a lot of treatments. So we might be in this situation where we have several experimental treatments, E1 to E3 here. It doesn't have to be 3, it could be more than that, or only 2. We also have several biomarkers, and we might have a control treatment. And hopefully, in most cases, we would have a control treatment. But in some cases, rare conditions or very rare biomarkers, we might not have a control group. So in this case, the arrows here indicate that we expect certain treatments to work in certain biomarker subgroups. So E1 we'd expect before the trial starts to work well for B1 positive patients, and similarly for E2 and E3. We might be more or less confident about those links. Maybe we've got very good evidence that those links are true. Maybe we don't have any evidence and there's actually no links here. The treatment might actually work in a broader set of patients instead of just the biomarker group we thought. So yeah, we can go wrong with these links. So which design should we use in this case? I'm going to briefly talk about 3 designs that you can use, and they're all suitable when you have different degrees of confidence about these links. So the first design is what I call parallel trials, and it's basically a set of parallel sub-trials that are undergone at the same time. And a patient will come along and have their biomarker profile taken. This is from a trial called the National Lung Matrix Trial, which is in lung cancer. So patients will be sequenced, and which mutations their tumour has will be determined. And based on that, they'll be allocated to one of several trials, each one testing a novel agent in a biomarker subgroup. Another example is Focus 4, which is being run by the MRC Clinical Trials Unit in London. Both of these designs have the same idea of multiple sub-trials, each testing a treatment, but they do differ quite a lot in other ways. And both of these approaches also use adaptive designs methodology, which allows you to stop individual sub-trials if the agent isn't doing very well on a group of patients. And that's very good because it means that you might be able to introduce a new targeted treatment instead if there's a newer one available, and you're less likely to be treating patients with an ineffective treatment. So that's parallel trials. The second design is called Bayesian adaptive randomization. This is quite popular in the United States, especially in the MD Anderson Cancer Center. I don't know if I've seen this outside of cancer, but I might be wrong on that. It doesn't make any assumptions between links between treatments and biomarkers. What it does is it starts by randomizing patients equally between the available treatments, and then using the data that you gather during the trial to kind of form links and to prioritize allocation of patients to treatments which have worked well for similar patients in the past. So patients more likely to get a treatment that's worked well for patients with a similar biomarker profile that's been treated previously in the trial. So that's suitable maybe when you don't have any links between treatments and biomarkers. When you do, but you might not be completely sure about them, maybe you've got some evidence that the links are true, but you don't want to completely assume it. You can use a kind of hybrid design that uses ideas from both of these. So this is a design that I worked on with some colleagues in Cambridge. I call it the linked bar design because it uses links between biomarkers and treatments, but uses Bayesian adaptive randomization to kind of change the links if the data in the trial shows that they're not the best links available. So here's an example from a trial that I'm involved with designing at the moment. This is in post-adjuvant breast cancer. So it consists of 2 stages, 300 patients in total. The first stage is 100 patients, and we have 2 biomarkers here, 2 experimental treatments, and a control treatment. And depending on which biomarkers the patient is positive for, they'll get allocated in different ways. So if a patient is positive for one of the biomarkers, they'll be allocated between the control arm and the treatment that is targeted at that biomarker. And it's a 1-to-2 ratio. That doesn't have to be, you can use an equal allocation if you prefer. Here, this is just a clinical decision. If a patient is positive for both biomarkers or neither, then they're allocated equally between the 3 available treatments. Then in the second stage, which is 200 patients, we do a series of interim analyses where we can use the data we've gathered so far and look at which patients are doing well on which treatments, see if that's consistent with these prior links that we've had, and if not, change them. So how do we do that? Well, I'm not going to go into this in any detail, but we fit a statistical model to all of the patients recruited so far at an interim analysis. And from that model, we can get the probability of each of the experimental treatments being better than control for each type of patient that we can have in the trial. And then those probabilities are used to allocate patients to the different treatments. So a treatment that has a high probability of being better than control will be more likely to get a patient of a particular biomarker profile than a treatment that actually has a lower probability of being better for that type of patient. The control treatment allocation stays at 1/3 throughout the trial. We're just varying the experimental treatment allocation. You can include the control treatment in this procedure if you want, but the danger there is that if you might have low power because you might have too few control patients. Just very quickly, these 3 designs, when do they work best? Well, we considered a few different scenarios in the design of the post-adjuvant breast cancer trial. If we have that, say, one of the treatments works well in all patients, well, in this case, we're assuming quite a big effect size, so all of the designs have very good power. We do get slightly more power from the designs using Bayesian adaptive randomization. That's because the biomarker 2 patients who wouldn't be given treatment 1 with the parallel trials approach are more likely to be given it with the Bayesian adaptive randomization approaches. So more patients will be getting treatment 1, which actually works well in everyone. If our prior linking assumptions is correct and treatment 1 works in biomarker 1 positive patients only, as we might expect, the parallel trials design performs very well because that's making the assumption that that's true and it's only randomizing biomarker 1 positive patients between control and treatment 1. Actually, we do pretty well with the link bar approach that we've suggested here. It's pretty much the same power. The Bayesian adaptive randomization itself, it doesn't have awful power. In fact, it's pretty close, but it does lose a bit of power here. If we got the prior linking assumption completely incorrect and actually treatment 1 only works in biomarker 2 positive patients, probably very unlikely for that to happen. But in that case, the parallel trials design suffers a lot in power, and our proposed approach retains a lot of it. It does lose some compared to the Bayesian adaptive randomization only, but it does pretty well compared to the parallel trials approach. So you really have to consider which of these scenarios you think is most likely, and if you think perhaps the second scenario is much more likely than the third, you might want to go with either the parallel trials or the linked bar. If you think the third scenario has a good chance, then you might want to go with either the Bayesian adaptive randomization or the linked bar approach. So to finish off, I wanted to talk a bit about quite an exciting type of trial, in my opinion, and this is an area I want to do a lot of research on in the future. It's got different names. I call it a Perpetual platform trial. Perhaps that has a slightly negative connotation, but actually it just means that you can keep adding in new treatments and new biomarkers as they become available. And this has a lot of advantages for efficiency, both statistical and kind of logistical and administrative efficiency. So I'm also involved in designing an ovarian cancer trial, and they're going to apply for funding to test a single targeted treatment against control with an adaptive enrichment approach that I talked about earlier. But the idea is that this proposal would form the basis of a perpetual platform trial, and as new agents become available, new biomarkers, we can submit new funding applications to add them into the trial. So it might look like this, where we start with control and experimental treatment 1, and as we go along in time, we add in new treatments as they become available. And in this case, we need to really have some kind of stopping rules about when do we have enough evidence that either the treatment is effective, and this is a phase 2 trial, so that would mean that it would go on to a phase 3 trial, or that we've got enough evidence to say it doesn't work in any particular biomarker subgroup, so we can stop for futility because it's just not very effective. So that's an interesting methodology research issue about these decision rules about when should we promote a treatment and when should we stop a treatment for futility. And also when should we add in a treatment. If we already have 10 treatments in the trial, we'd probably be less keen on adding in a new treatment than if we only had one, because adding in a new treatment when we have 10 probably means that we're not going to have much power to test it. And the final slide, so I'm a statistician, so I'm probably the wrong person to talk about this, but I wanted to briefly talk about some practical challenges from these type of trials, and particularly in when we're using biomarkers prospectively in trials instead of doing a retrospective analysis at the end. In that case, we really need to be able to determine a patient's biomarker profile very quickly, within a few weeks if possible. If it's going to take months and months, we're probably not going to be able to use the biomarker information very effectively in the trial. If we want to consider platform trials with multiple treatments, multiple biomarkers, then this does cause some logistical issues. So all of the centres in our trial need to have access to all of the treatments, which might be challenging to do, especially if the number of treatments is high. For adaptive studies, where we're using data as we go along, we really need an endpoint which assesses whether a patient is doing well. That needs to be observed relatively quickly after recruitment. If we're doing a study where we're recruiting patients for 3 years and we have a 5-year outcome, then by the time we've got the information on the first patient recruited, we have already finished the recruitment for the trial and there's nothing we can do to change anything. Whereas if we had maybe a 6-month outcome or even shorter than that, there might be a lot of things that we can do adaptively to benefit both the trial's power and the ethics of the trial for the patient. We also need interim analyses to be done very quickly. We can't be taking a year to do an interim analysis because that's effectively adding time to the delay in assessing the outcome. So I think there's a lot of challenges, both statistical and non-statistical, but I really think they are being overcome in real studies. So I think all of these type of trial designs, they can be used in practice in certain circumstances, and I hope you might consider using some of them in the future. Thank you very much for your attention.